ILADS versus IDSA, the Lyme debate. This is part of a common sense Lyme disease series where I discuss cases that I've seen and questions that are commonly in my practice. I'm Dr. Cameron. So let's begin. Now the patient has a dilemma. They might have severe fatigue, poor memory, poor concentration, lightheadedness, neuropathy, joint pain, and they see different doctors. So there's one group of doctors that tends to assume the infection is gone after 30 days. There's another group of doctors that have said that there's possibility of a persistent infection, but who's right? Now the IDSA is you can characterize as being by the book. The diagnosis requires clear evidence. 10 to 28 days is enough, although they do allow for a second month if it's Lyme arthritis. And they often use the word post-treatment Lyme disease syndrome. That is, it's a syndrome after you've had 4 weeks of therapy if you're still sick, and there's no evidence of ongoing infection, and they avoid long-term antibiotics. Now, ILADS, the International Lyme and Associated Disease Society, I was a board member. I was the first author for 2 of their evidence-based treatment guidelines, where we took a different approach, looked at the evidence in a different way, and came to the conclusion that we should be open to clinical judgment, even if the tests aren't accurate. There should be flexible treatment guidelines, screening for co-infections, including Babesia, and shared decision-making. Now, each side offers something. Now, IDSA tends to take more of a standardization approach, population level, safety, trial-based evidence. Now, they often refer to the NIH sponsored clinical trials to try to see if they can address this question, but so far the clinical trials have been problematic. For example, the Columbia NIH sponsored trial, patients were sick for an average of 9 years. They had already failed 2 previous treatments. They looked at fatigue and they were much better, but the concentration and memory did not change for the long run. They didn't look at whether there was a role of a co-infection in these patients who failed treatment. ILADS says that you still can't address these issues in a NIH trial yet, or at least you need new designs. ILADS emphasizes clinical judgment, individualized care, and responsiveness to patient experiences. So the takeaway is that patients need to be heard. Medicines needs to be balanced. So there might be an IDSA view, an ILADS view. And there's also, as a doctor, each person went to medical school, has their own experiential level, and real life matters. So in other words, if you see a patient who's confused, it's reasonable to at least give them an overview of the different perspectives. I do that all the time so they know that the approach that I take is not the only approach to treatment for Lyme disease. Thank you for joining me for this Common Sense Lyme series. Have a good day.